of my talk. And I think, since we are using the app and all these things, there's the good, there's the bad, and there's the ugly concerning this topic. Does it work? It doesn't show really. Okay. So let's start with the good. Another thing, ASD closure is a success story. So as already shown by Dr. Grohmann, it's something done really early. We heard in the morning as a talk about the congenital heart surgery and the history of it. And it's really a success story. And it's also shown by a study from Rotterdam where they looked at patients with ASD which were closed as a childhood. And this is a 35 years follow-up of these patients. 51 patients compared to a control group. And since my topic is the left side, I concentrated on the echo diameters. And you can see that end-diastolic dimensions and systolic dimensions, fractional shorting. You can also do a Simpson. Everything is the same compared to a control group. And when you look at systolic function, it's normal in most of the patients. And you have to keep in mind these were operated more than 30 years ago. So at that time point, the cardioplegia we used at that time point and all the obstacles we had. So very good outcome. And this is also the same cohort in a different publication. And they looked at the survival, and they showed that the survival compared to the Dutch population is quite normal, it's the same. The event-free survival, it's not the same. It's mostly arrhythmias which occur. And then this is a study where they also looked at the same cohort now using strain echocardiography, and they showed that even using this more modern imaging technology, you can see no difference to a control cohort. So on the left side, everything is fine. And if you compare transcatheter closure and surgical closure, Dr. Grohmann touched on this issue, the results are quite the same. This is New York Heart Association class. And you can see that it's more or less the same for both groups, so it doesn't make quite a difference if it was done surgically or transcatheter. So what's the bad thing? Well, this is a larger cohort. This is from the CONCOR registry, which is a large registry of adult congenital heart disease patients in the Netherlands. And they looked at more than 2,000 patients with an ASD. And they did a long-term follow-up study of these patients. They could show if you're female and you have an ASD, your probability of survival is the same as the normal population. But if you're a male and have an ASD, your probability is a little bit worse. You can see it starts around the age of 50 and then it goes down. So, sorry guys, but the females are better off than we are. And what also happens is they looked at the adverse events during this long-term follow-up, and they could show that the number of patients with supraventricular tachycardia, so atrial fibrillation, atrial flutter, and all these things is increasing the whole time. So at the age of 70, your chance to have some kind of supraventricular tachycardia is 30%. And also pacemakers, heart failure admissions, these all increase. You also have to keep in mind this also increases in the normal population, but still 30 to 40% of supraventricular tachycardias is quite a high number. And if you look at risk factors for late arrhythmia occurrence in these patients, this is a study by Shelby Cutty comparing the data of Nebraska from the university there with the Cleveland Clinic. And you can see that age at the procedure is a very important risk factor. So if the patient is getting older when the procedure is done, the probability of getting some kind of tachycardia is quite high. And also if you have a pre-existing atrial arrhythmia, then the chances that it stays and sustained even after closure is quite high. And this is not news, so it's not something we didn't know before. Michael Gatsoulis during his time at Toronto looked at this issue. And he compared patients who were operated on and patients who were not operated on from the Toronto Cardiac Base. And these are more or less the first patients operated on for an ASD closure in Toronto. And you can see the same thing. Patients over the age of 40 years at time of surgery have a much higher risk of developing atrial fibrillation or atrial flutter. And now it becomes ugly. This is a patient of ours, similar to the patient Dr. Grohmann showed, which we did a cath in March. And this is a 62 years old lady, which has signs of heart failure, so she was symptomatic. And she had also atrial fibrillation, which was persistent, not permanent, but persistent. And this was the cath we did. And as you can see, the pressures in the left atrium are quite high, with a mean pressure of 12 and diastolic pressure of 15. And when we test occluded the ASD, the pressures even increased more to 23 to 32 to 22. So we couldn't close this defect, but still the patient was symptomatic, and we didn't find anything else. But this is diastolic heart failure. So the question is, do we close this thing, or leave it open and say everything is fine? And then we have the chance, the opportunity that we have a trial, a randomized trial, which is quite rare in congenital heart disease. And colleagues from Mexico looked at this issue, and they looked at patients over the age of 40 years and compared them if they had surgical closure of the defect or just medical treatment. So the collection of the data was done in the 90s, so it's more or less before transcatheter closure was quite common everywhere. And they were able to include more than 400 patients in this study, and 232 were assigned to surgical treatment, and 241 were assigned to medical treatment. And they looked at the composite endpoint combined of arrhythmias, heart failure, death. And when we compare both cohorts, they are quite similar. There's no quite difference. The age at entry is over, various patients over 40 years, but also some patients over the age of 60. And the follow-up is quite decent with 7 years. And they show that if you close the ASD, the chance to suffer from the endpoint is much lower than if you have just medical treatment. So there is an indication to close this holes even in older patients, in elderly patients. So coming back to our patients, we can't close it in this way. So if you close it, this patient will go into diastolic heart failure, probably in pulmonary edema, and we are in trouble. So the group from Berlin published a way how we could do it. They had a few patients which they pre-treated, and they did a conditioning, that's how they called it, and they gave them Myrinone, furosemide, and dopamine. And then they did a test occlusion before the conditioning. You can see that in the test occlusion, the pressure goes up, and after the conditioning, the pressure didn't go up as much, and you could close the hole. And it's quite reasonable to have this approach. And if you look at the guidelines for heart failure, for diastolic heart failure, which is called now HFPEF, which means heart failure with preserved ejection fraction, you can see that there's more or less only 2 recommendations, which is quite unusual for our cardiology. So if you look, for example, for systolic heart failure, you have a lot of recommendations what you should do and not do. Well, more or less it's the same. You have to look for comorbidities and treat them. So if you have patients with atrial hypertension, you should treat it. And then diuretics could work to elevate symptoms in the science, but it doesn't impact on outcome. Everything else which was tested, there's a large table in these guidelines listing all kinds of medications. Every study was negative, so nothing works. So what we did is we just gave this patient diuretics, so intravenous furosemide, and also we did a cardioversion, so we put the atrial fibrillation back to sinus rhythm. And then after a few days, we did a cath again, and as you can see, we now could do a test occlusion. The pressures didn't increase, and we could close this hole. And HFPEF, on a side note, is an epidemic. So these patients are coming and are getting more and more, and we all will see them. So even if you only do congenital cardiology, your patients are getting older and they will develop HFPEF. And the problem, as I showed you, is we can't treat it right now. We don't have a really good treatment for these patients. We can elevate their symptoms by giving them diuretics, but nothing more. And you can see there's a large increase of this type. So HFPEF is getting more. Patients with HFrEF, which means heart failure with reduced ejection fraction, are getting less because the treatment is getting better. So patients who suffer myocardial infarction get to the CASP soon, and all these things impact on these outcomes. And if you look at this data, sometimes you wonder, are we doing the right thing? Because in the diastolic heart failure community, without any congenital lesions, there is a trend to think about creating a shunt on the level of the atrial septum. So this was a study, this is a phase 1 study led by Professor Hasenfuss from Göttingen, where they put in a transcatheter in cardiac shunt device. which looks like this, to create a P for an ASD. And the idea is to lower the left atrial pressure and so help the patient with the symptoms. And it actually seems to work. So this is a 6 months follow-up data, and you can see patients who were before in NIHA class 3 or 2 improved to class 1 and 2, most of them, not all of them. But this is an approach, and a phase 2 trial is now ongoing, and phase 3 trial probably also. But we are closing a hole, and the other ones are creating it. So I'm not quite sure if we're doing the right thing. The thing is, this patient, the 62-year-old patient, got better. So her symptoms decreased, she feels better, she has a better quality of life. On the long term, I don't know. So otherwise, you can discuss what is the long-term outcome for a 62 years old. But we really have to think about these things. So I would like to conclude that ASD closure is a success story. So on the right side of you, on the left side of you, I think it's a success story. Old age closure increases the risk for left-sided problems, atrial fibrillation, diastolic dysfunction, all these things. And regarding the closure of ASD in HFPEF patients, I'm not quite sure. I think the jury is still out. We have to collect more data to be more sure what we are doing. Thank you.